All right, welcome everyone. We are excited to have you all here, and it looks like we were able to get the technology to catch up with us. So we are ready to go. My name is Norm Thurston, and I am the Executive Director at the National Association of Health Data Organizations, and we are so excited to have you with us today for our webinar on expanding voluntary data collection and how that relates to the power of all-payer claims databases. This topic is especially important because if you think about all of the different types of data projects out there, it's rare that anybody would have the authority to compel mandatory submission of data for any particular data project from everybody that you would like to get data from. So almost always, if there's a data project, there is somebody that has to be a voluntary submitter, whether that's an all-payer claims database or something else. There's always this question about, well, how do you get the data that you want when you don't have the authority to make somebody do it? So a critical topic for today. We're going to hear from some states that have been working on this for a very long time. This webinar is sponsored by NATO and with our partners today, WellStack. And so we're glad to have WellStack on with us today. So today's agenda, we're going to, first we're going to do some introductions, and then we're going to hear three presentations from our three presenters today. And then after those presentations, we're going to accept questions and have a Q&A session with all of our panelists. So at this point, we're going to remind everybody that you can use the chat function to submit your questions. Those will be addressed at the end of the webinar in that Q&A session. And if you have a question that is for a specific panelist, please make sure that you address them directly so that we can make sure that those get ready to answer that question. All right, so our three panelists today, first we're going to hear from Craig Wilson, who is the Director of Health Policy at the Arkansas Center for Health Improvement. Then Peter Sheehan, who is the Vice President of Client Relations and State Initiatives at the Center for Improving Value in Healthcare in Colorado. And finally, Dana Richardson, who is the CEO of the Wisconsin Health Information Organization. So this time I'm going to turn the time over to Craig. Craig, whenever you're ready, go ahead and start.
All right, thanks, Norm, and thanks to NATO and to WellStack for hosting this today. Good morning or good afternoon, wherever you are from Arkansas. Glad to be here to talk about our efforts here within the state with some of the large employers that we have here. Norm, if you'll go to the next slide there. Just a little bit about our center here. I think I find ourselves to be quite unique in the kind of the health institute space. We are a nonpartisan independent health policy center, but I like to describe us as kind of working end to end. We have two very large data assets, one being the Health Data Initiative, which we've administered for nearly 20 years here. And I'll talk a little bit about that more. But we also have the APCD and the Healthcare Transparency Initiative. But also we're a policy shop. So we have historically used data to turn it into information and translate that into usable products that move the needle on health policy. We also have an affiliation with the Academic Medical Center here. So we use our data for health policy research mainly, but for broader research projects as well. We run some programs here. And then we extend that into advocacy, inclusive of providing testimony to legislators here locally, as well as at the national level. We are, as I mentioned, housed within the Academic Medical Center of the University of Arkansas for Medical Sciences, but we are separately governed. We have a separate board that governs our policy objectives. And since 2015, we have administered the Healthcare Transparency Initiative, which includes the state's all-payer claims database. Next slide. So within the Healthcare Transparency Initiative, it includes the mandatory all-payer claims database, which we have all of the fully insured commercial plans with covered lives within from within the state of 2,000 or more covered lives. We also include Medicaid and Medicare, but one of the things that we wanted to strive for, and that I think is in part a little interesting about what we have here, is we do include any state-funded self-insured plans. And so that includes our state and public school employees and any of the higher education institutions that receive state funding. So while those are plans that are, of course, governed by ERISA and would normally be not subject to any state mandate. We have a little political leverage on those plans to require them to submit here in the state. So we do have some significant experience with some of the self-funded plans, although with leverage. And then in addition to the all-payer claims database and the transparency initiative, we include by mandate, statutory mandate, birth certificate and death registry data, cancer registry data, workers' comp claims, and then to kind of close out a little bit of the absence of gaps for individuals who don't have insurance. We do have uninsured hospital and emergency room discharge information. And then recently we also included medical marijuana information, and that includes the card registry information as well as dispensary data, which we are just recently taking in. Next slide. So our structure, which I think from a voluntary submission standpoint, I think gives us a little credence. Our structure is through the transparency initiative is governed through the Department of Insurance here in Arkansas. But we are actually, as the center, named legislatively as the administrator of the database. So we have some, I think, credence, a little bit different from some other states that have contracted out the administration of the all-payer claims database. We have been legislatively named, and are, within the academic medical center, we have a little bit of credence in having that cover of being named as the state's administrator in statute. We have about 60 submitters, which represent almost 60,000 plans, and that's in addition to the other public sources that we take in. We have almost 10 years of data. So even though it was established in 2015, we included in the statute a request to go back to 2013 to do some analyses before Medicaid expansion, in particular in 2014 here. Next slide. So we have had some voluntary submission activity very recently. We have some engagement in Northwest Arkansas, which is one of the largest growing populations in the nation, and that's where some of the largest employers in the nation are located, including Walmart, Tyson Foods, and JP Hunt, which is a transport company. And they are in the midst of really a lot of economic development, and that includes in the healthcare space. So they're in a situation where, compared to other states where supply doesn't meet demand, but that's primarily because there's a lack of populace to support a supply there. This is an area of the state that is growing rapidly. They add about 500 people on a monthly basis. They plan to grow exponentially over the next 10 years, and they already have demand that is exceeding their supply. In fact, they've got such a demand that Alice Walton, in addition to the now 3 medical schools that we have, including the University of Arkansas for Medical Sciences, they're developing their own school of medicine up there, which is going to take a little bit of a different approach, but they see the supply need and want to develop their own pipeline. So we have a formal ask through the Northwest Arkansas Council, which is kind of the economic development coalition up there, to request voluntary submission for probably it's about 16 large employers up there that are participating in some of the value-based payment developments up there that that are going on aside from some of the statewide efforts that have been developed over time. Next slide. So some of the advantages that I think that we have as a state and as an all-payer claims database to be able to kind of get over this hump. We at the center, as I mentioned, we've got a 20-year history with voluntary submission through what's statutorily named our Health Data Initiative. It's a permissive database. We have historically had that in place to allow for the center to receive data, individual identified data, and be able to integrate that and manage it for policy development. Now, it has been limited for policy development. So we have had all of the processes, including the navigation of those legal arrangements, in place for a long period. We have had some success in having a couple of those executed with a couple of voluntary submissions as part of that effort. We have also had, for about 10 years, some statewide multi-payer payment reform efforts that we've kind of tried to bring the large employers within that umbrella so that they can participate in those efforts as well, with some relative success, with some relative failure. But I think that's an important part of the salesmanship on this is having some shared goal with your Medicaid program and your fully insured payers. We have that state-funded self-insured payer experience of taking in the state and public school employees and higher education organizations. And then we have our hash ID process, which takes the last name and date of birth from an identified data set and translates that into a 44-digit number and anonymizes it and is able to link with other data assets that we have in the database. So that's part of, I think, our advantages. On the other hand, on the next slide, we do, like many other states, I think, have some barriers. All of the companies that were named on that slide before, Walmart included, they're multi-state and international companies that operate outside of Arkansas as well as within Arkansas. And so their interests are not just Arkansas. So that makes it a little more difficult to sell them on providing just Arkansas-based information into the database. Second, as we all share that value proposition or the business interest in actually submitting that data, which includes some cost with it because they're working with third-party administrators that are going to cost this out and then charge them for submitting the data to the all-payer claims database. So finding some of those business interests, I think, is important. We've done some of that with the state and public school employees and looking at their relative increase in telemedicine use over time and comparing that to some of the other payers within the state and figuring out how best to pay for telemedicine, who's paying for what. Then the third barrier there is, I think, some risk and potential exposure of the contractual leverage that many of these large employers have. We seem to think that probably their reimbursement rates are lower than what you would otherwise see in some of the rest of the market. So there's some potential exposure there. And generally, I would say that these large employers are just weary of government involvement generally. Certainly within the data aspect, but more broadly in terms of regulatory oversight or interference or entanglement. So I think there's just this general notion of they don't want the government involved. Next, there's the shift in non-claims-based payment, and I think that many APCDs are trying to figure out how to bring in non-claims-based payment structures that are flowing outside the claims. And, these large employers have been doing a lot of that. So trying to figure out how that measures up to some of the other payers, I think is a difficult conversation to have. And then one of the things that challenges that we've had with some of the state-based self-funded plans is just the changes in their third-party administrators and pharmacy benefit managers over time. Some of them are changing them every 2 or 3 years. And so that makes it difficult to go back in time and do some trends over time with these large employers. That's all I have. Thanks.
Okay, great. Well, thank you, Craig. Next up, we have Peter Sheehan, the Vice President of Client Relations and State Initiatives from CIVHC. Peter, go ahead and turn on your camera, take yourself off mute. Great, thank you.
Thanks, Norm, and thanks, Craig. That's a lot of information on Arkansas. We're not quite that far along here in Colorado, but I'll share a little bit about Civic, what we're doing on this in this area, and we'll go from there. So we are an independent nonprofit providing data analytics and project evaluation services to a broad array of organizations within healthcare and also outside of healthcare, including government entities, researchers, digital health organizations, and others. We do administer the Colorado APCD on behalf of the state of Colorado. We enjoy a close working relationship with the state, and much of our work is directed through the Colorado Department of Healthcare Policy and Financing, which runs Medicaid here in Colorado. We are not a state agency, however, but we are celebrating the 10-year anniversary of the work that we do administering the Colorado APCD. Next slide. Over the past 2 years, the Civic team has developed a Colorado APCD Insights dashboard, which is an alternative. It's an interactive tool on our website that can be used to explore data that's contained in the Colorado APCD. This tool allows people to take a look at the data by year, by population, by payer, and by claim volume at a high level. In just at a very high level, what the database currently includes is 870 million claims. We're receiving data from 36 commercial payers through 2021. The database does include Medicaid and Medicare as well. We currently do not receive claims for federal programs and the majority of ERISA-based self-insured employers. We also don't have self-insured or self-pay claims. I'm sorry, we do include some of the self-insured, we just don't have the majority of them here in Colorado. We estimate that we have approximately 70% of the Medicare and the medical covered lives within the state. Next slide. Here in Colorado, commercial plans are mandated to submit data to the Colorado APCD. We've been working with our partners to educate the business community and receive more of the voluntary submissions of the self-insured claims. As I mentioned, we do enjoy a strong partnership with the state. And through that partnership, we've set a mutual goal of increasing our self-insured covered lives by 10% each year. With the state and several of our other partners, we include programs and strategies focused on outreach and education based on sharing the benefit of submitting data. One of those benefits is having the data in the data warehouse and our ability to generate analytics and data through reports that support their initiatives, which within the state of Colorado, we're split kind of geographically into the Front Range, the Denver metro area, the Eastern Plains, and the mountains. And specifically in the rural areas, the mountains and the plains, healthcare costs can be high, and the employers, many of which are small employers, are trying to get their arms around those costs and work through purchasing alliances to do that. So our efforts really focused on working through those groups, both with the state and with others. One of the things we did see last year is a 29% growth in the self-insured cover lives in fiscal year 21-22. However, I do want to mention that that metric was based on receiving an eligibility file that came back from one of our payers. So although we did see growth, was also just getting more information to the database that we should have had previously as well. Next slide. Our partners on the employer front include Peak Health Alliance, the Colorado Business Group on Health, the Denver Metro Chamber, and others. That focus, as I mentioned, is on that local level, self-insured employers, helping them understand why their costs are the way they are, if they have data within the data warehouse. Through the Denver Metro Chamber, one of the strategies we undertook was to work through the brokers, trying to help provide that education in the value of submitting data into the warehouse. There is no charge from the Colorado APCDs to submit, but as Craig mentioned, in Arkansas, there can be fees associated with doing that through the TPA or the administrator. There is a process that we use or have that on our website, just walking people through how to opt in. If you go to the next slide. This you can find on our website. The link is here. It's included in the slides, but it's step-by-step instructions that can be used by brokers, can be used by employers themselves on how to complete the opt-in form. There's a BAA that can be reviewed with TPA and ASO. And then there's a data sharing agreement with CIVHC that is an optional document. But that's all available on our website. If anybody want to take a look at that and just see how we're trying to get people educated on how to opt in. It's a pretty simple and straightforward process here in Colorado. Next slide. We tried doing this on our own and found that working through partnerships is the easiest way for us to try to educate people on the benefits of doing this and why the data should be in the data warehouse. It creates an ongoing and open dialogue through trusted partners like brokers that already have those relationships, or other groups like the purchasing alliances. It also helps us get feedback in terms of the data and the reports that we provide that helps us continue to enhance those reports and make them more valuable to the people that are actually using them. Let's go to the next slide. This is just a list of the reports that we created. Through the partnership with the state, they provided resources and funds that allowed us to actually put in place the development of reports specific to employer needs. So a few of the things that we did is create an employer snapshot where employers, if they have enough data in the data warehouse, we can show them what their costs are as a % of Medicare. We can also show them potentially avoidable ED visits specific to their employee population. We have a low value care report. I know a number of the other APCDs use the same tool. We use the Milliman Insights tool. We also have focused reports on top 5 procedures and potentially avoidable costs using an episode grouper that can be run at the employer level as well as at the alliance level. And we have a pharmacy cost generic substitution analysis that can also be run, as well as looking at inpatient, outpatient utilization and drug costs as a total cost of care type of analysis. Let's go to the next slide. And although we've put a lot of effort into those reports, they've received limited traction with the employers. The alliances, there's 3 major ones here in Colorado, have found a great deal of use by looking at our data to try to get their arms around costs in their specific region of the state. We've shared those reports that I just mentioned as well, and we've gotten feedback on them. But when we've broken things down to the individual specific employer level, we found that we ran into some challenges with regard to suppression due to low volume. When we found that, we rolled things up to the county level and sometimes even the state level to give them some level of insight into what's going on with their costs. But there have been challenges. I believe that's all I've got from CIVHC.
Thank you, Pete. That's fabulous. Now we're going to go ahead to our next speaker, Dana Richardson, CEO at Wisconsin Health Information Organization. Dana, if you want to come off mute and turn your camera on, we're ready to go.
Well, great. Thank you very much, Norm, for inviting us to participate. You can go to the next slide. So WHIO is a little bit different model than I think most APCDs. We do have state statute that initiated the collection of administrative claims data to analyze and publicly report on cost, quality, and the effectiveness of healthcare. But in that legislation, the data submission has always been voluntary. So that puts us in a little bit different space than I think many other states are in. So next slide. So in response to that legislation, the Wisconsin Health Information Organization was created to actually fulfill that requirement on the behalf of the Department of Health Services. And we have always held that contract with DHS, but we are an independent 501c3 501c3, and we are viewed as a partnership between the state of Wisconsin and private sector organizations, including health plans, employers, provider organizations. Despite the fact that we're a completely voluntary data submission state, we have data on about 75% of our population, and it spans pretty much across the entire state. You can see the map on the bottom of this slide where the northern portion of the state is kind of sparse, but that is the northern portion of our state. We just don't have a big population there either. We get claims from, you can go to the next slide, thank you. Sorry. We get the administrative claims data, so eligibility, medical and pharmacy, from multiple different organizations. Right now, we have about 18 data submitters, but those change as some go out of business and some are consolidating. But really, since the beginning, we have received data from national health plans, some state and regional health plans. We have a fair number of those in the state compared to other states. We do get data from one self-funded employer coalition. We have another employer coalition here in the state that's been very supportive and worked pretty hard to get their self-funded employers to submit the data, but the challenge really has been that the TPAs have not been willing to do that. And then we also get the data from Medicaid. So we have the same data limitations as I would say the other data submitters do. What we learned early on is voluntary submission only is a very time-consuming and slow process. So in 2012, the Wisconsin Department of Employee Trust Funds, which is the state's healthcare health plan, essentially for both state government as well as county and local government employees, instituted really language into their contract that said that if you are going to be a health plan who provides services to our members, then you have to submit your data to WHIO. And that includes both the commercial and Medicare Advantage data and your entire book of business. And so with that new contract language, which is often referred to here as a quote unquote soft mandate, we saw a rapid increase in data contributors. However, we are a little bit at the, I guess, the whim of who ETF includes as their provider health plans. So if someone leaves ETF, then they would have the option to leave data submission to WHIO, and sometimes that happens and sometimes it doesn't. The other thing is that it has made it more difficult for us to require the submission of allowed amounts. So we do get allowed amounts from about 60% of all of our claims, but not 100% of the claims. So that's been a little bit of a hindrance for us. Next slide. So I really think of the data submission process as being kind of interrelated and linked to our business model, as well as the products and services that we provide, because they all kind of have to fit together. So in 2008, when we started, and the state was a strong partner in the work that we were doing, there was actually funding that we received through a physician tax. And then that constituted about 40% of our revenue, and the rest of our revenue we were required to make up through the sale of subscriptions to accessing a de-identified data mart product that we offered at that time. However, in 2013, we had a change in governor, and that governor had a different perspective on taxes in general. It wasn't personal to WHIO, but he eliminated that physician tax, at which point we lost 40% of our revenue pretty quickly. So in response to that, DHS actually brought in a CMS grant that helped to fill in some of that vacant revenue for us. up through 2016. And since that time, we have not received any state funding, with the exception of some project-based work that we do for the state. Next slide. The other component of this is that when we first started in 2008, we made a buy decision. So we purchased essentially a product that was provided to us by a data vendor. The product itself at the time was certainly state of the art, but you can imagine over 10 years' time, as technology has changed so dramatically, that product actually became less valuable to the organizations that were on our private sector side, helping to fill a lot of our business model. We ran into some inflexible pricing, and they wanted some pretty big dollars to do any additional work for us. So in 2018, we transitioned to a new data system, and we've really rebuilt the system using state-of-the-art technology so that we can actually provide multiple products and services to meet the varying needs of our different customers. Next slide. My little thing is sitting in my way. Here we go. So there's something missing on this slide. I don't know where it went, but I have a little, there we go, a little graphic on the left-hand side that says, these are our current products and services. So we went live with our new data system in the middle of 2019, which of course with COVID coming unknown to us, was not the best time to transition everything over, but that's what we had planned on. So that's what we did. So we now offer different products and services, and we gain our revenue really across all of these different opportunities. So we have something called Intelligence Bank. That product line includes our de-identified data marts. They are predominantly used by health plans, quality improvement organizations, and researchers. So these are pretty large data systems. They go back to January 1st of 2017. In the case of the standard integrated data product, it is a longitudinal product that we keep adding to. So you can imagine it's very good to be able to do before and after types of analyses. And we do include a non-intelligent key so you can link all the data together. So we have several customers who use this product. We also have a product line called Applied Insights. These are pre-built web accessible reports, often used by organizations that don't have a lot of analytical resources within their own organization, or they're just very busy and would like to use some of our reports, so predominantly health plans and provider organizations. I would say over the last year or so, particularly since COVID started, we've seen a big increase in the use of our custom analytics. We do a lot of file extracts for research organizations. We've been able to leverage some third-party software to do data hashing, to be involved in multi-data source types of research projects. And then we've been doing custom reports. So again, we have a broad array of organizations that use our custom analytics, but predominantly researchers, provider organizations, associations, and then state organizations. And then finally, we do some education training, and we provide information to the public through a publication called Info Bites. And that's really focused on what seemed to be at the time some of the critical policy decisions that are being discussed within the state. Next slide, please. So some things that we've learned over the 10, 12 years we've been doing this is that, voluntary data submission as your sole model of data submission takes a lot of your time and energy to keep it flowing. So I would not necessarily recommend it. If you are able to, get a mandate, at least for some of your data contribution, to me, that would be ideal. However, if you can't, you can create a database through voluntary data submission. The ETF soft mandate has been very helpful to us, but still it's a voluntary system because any health plan, for example, could choose not to be an ETF health plan, although they have a lot of covered lives and a lot of clout, so that doesn't happen very often. I think the key thing that I have learned in the time that I've been at WHIO is in order to get organizations to submit their data to your organization, and at the same time we do require them to pay a fee, we have to give them something of value back, right? So when you think about, when I talked about our products, some of our products are actually geared towards helping the health plans and the employer coalitions and Medicaid, who all really provide the data. We gear some of our products directly towards their needs such that they think they're able to continue and want to continue to contribute the data back to us. Next slide. From a business model perspective, I have learned that we started with at least a significant portion of our funding being state funded, about 40%. However, as our state has changed its culture, so too has the thinking about, is an APCD a public utility or is it a private industry type of information system? And so I think to myself, we were only one election away from losing all of our public funding. I think the founders of WHIO, I wasn't here at the time, but they relied too heavily on state funding. So when that happened, we were kind of caught short. And as all of us know, you don't create new products in complex data systems real quickly. So it took us quite a while to kind of retool and be prepared to be able to do that work. I would say that there are many more competitors now in the private sector solutions market, and we're a very small fish to have to compete with them, which means to me that we have to be really much more closely aligned with what our customers are looking for. And the key to at least our success so far has been to diversify our business model. Next. I would also say that today's technology is much different than it was years ago. As you know, you can create a lot of different products and services. But as I said earlier, there's many for-profit competitors in the market. We actually use WellStack, who's sponsoring this webinar today. And, for us, they have been a very savvy partner. They've been willing to work really and change direction on a dime when we've needed to do that. And they've been willing to invest in innovative products and services with us. So, if at any point you are looking for a new vendor, I would certainly consider kind of the culture of the vendor in addition to the technological capabilities that they have. I think that is all I have.
Fantastic. Thank you, all of our panelists, for sharing their experience. At this time, we'd like to take some questions from our attendees. Please put them in the chat. We have a few questions that have been preloaded, pre-submitted, so we'll go ahead and go with those first. But by all means, please, everybody, drop your questions in the chat. So let's first take a question for Craig. Craig, how would you respond to an employer who would prefer to rely on publicly available data on payments that are now required, in theory, to be disclosed by hospitals and insurers, rather than submit to an all-payer claims database? What's the difference, and what case could you make to those employers?
Yeah, I think you said it under your voice. I think the critical piece there is in theory, right? They're required to, but we've seen some significant, I would say, non-compliance with those mandates. And even if there are attempts to be compliant. When they are, they're in a format that is either incomplete or incompatible, and something that's not very useful in particularly looking across the different hospitals or payers. And then I would say as well that if they are going to be compliant, that's largely just payment information. And so that's very limited. And although, large employers who are looking at voluntary submission, that might be one of the primary things that they want to look at is their comparison in rates to others. It's not going to tell you anything about comparative utilization or patient behavior, and those things are ultimately going to be important and are always important, certainly in a policy conversation about even small p policy about what the business is going to do. And then I think lastly, for a lot of the large employers, particularly when you think about employers like Walmart, a lot of their employees are on the lower end of the income scale. And a lot of them aren't going to take up employer-based insurance because of the cost. And so many of their employees are going to be on Medicaid or other subsidized programs. So, they have an interest, just like we do, in having a more complete picture of what's going on. And I think that's something that they would really need to think about in having a more complete picture of the healthcare that their employees are utilizing.
Great, thanks. So we've got a few questions here now that are starting to roll in. So the first question is from Olga Arma, and I'm not sure if I'm the only one that can see these or if everyone else can see them. So I'll just go ahead and read them out loud. How did you identify your partners and bring them to the table? And I think that could be to any of you, but I want to maybe toss that to Dana first and see, Dana, if you've got a short answer for that one, and maybe Pete could take a crack at it as well.
Sure. So in our, governance structure is really where that begins, because our governance structure requires that we have representatives from health plans, the business community or employers, provider organizations, and then state government. So we have always functioned as a really multi-stakeholder governance body. And, that really gives us the ability then to leverage out through their networks and create partnerships, through both our board member organizations, but others that they know, which gets us well connected with others in the state. As far as partnerships with, say, third-party types of vendor organizations, I'll say that we have evaluated quite a few of those and not actually gone into partnership with a lot of them. So for example, I've probably looked at half a dozen or more predictive modeling systems. I would say the vast majority of them are not ready for prime time. There's one or two out there that I've found, but at least in Wisconsin, I don't think our provider organizations, who tend to be a little bit conservative when it comes to these types of analytical systems, I'm not sure they're really ready for that. So we've only built a few pretty select partnerships over the course of the last 3 or 4 years.
Hey, Pete, what are your thoughts on that one?
So in the context of partners being community partners that help us try to bring in more voluntary claim submissions, a lot of it was driven through our relationship with the state, but also similar to what Dana just described, we serve a multi-stakeholder population or constituency group here in Colorado. They have a lot of interests in how the data is used and come to us with requests. And then just more recently, specifically here in Colorado, there was a law changed about 2 or 3 years ago that allowed certain nonprofits to become purchasing alliances. Those purchasing alliances are driving a lot of the conversation to use data to help educate those small businesses, specifically in the rural communities, about the benefit of having their data in our data warehouse, getting an understanding of their costs, and then moving forward with their own strategies to try to address those costs.
Okay, great, thanks. there are two questions here, one from Meredith and one from Natalie, that I'd like to combine into one. And Craig, if you just take the first crack at this, we've got a lot of questions coming in, so I'm just gonna rotate around and give each of you a question. But if you have something burning on your next shot, go back and say, hey, on that last question, here's something to do. But so from Meredith and Natalie, first of all, how do you identify businesses that are self-insured? Because is there a list somewhere? And the second one is, she lives in a state, Meredith lives in a state where there are not strong business coalitions. So how do you go about, what are your strategies for engaging employers for this voluntary submission? I think both of those apply to your case, Craig, in Arkansas.
Yeah, there's no, I would say there's no single solution in trying to figure out which companies are self-insured. It really is for us. I think it's a lot of grassroots work. We are, of course, a small state, so it makes it much easier with 3 million in population, and you know, we can kind of gauge from the data that we have, the percent that we don't. We think we have about 80% of the covered lives in Arkansas. And, you know, you can do a little bit of backing into where you have gaps on a population level. So in looking at the percent of covered lives that you might have in particular counties, and then you can see where you might want to target some engagement, and you might be able to identify through a back-end mechanism those entities that are self-funded. And then what was the second question, Norm?
Yeah, it's basically the same thing. So if you don't have a strong business coalition, how do you do it? But I'm just guessing that one of the things that we had here when I was working in Utah was there was a state agency that would tell you for any geographic area who are the largest, maybe the top 10 employers. And I'm guessing that most state economic development offices have those lists. Is that true of, I'm seeing nods from Wisconsin and Arkansas. Pete, Colorado has, I'm pretty sure, right?
Yeah, it certainly is here, and we have also a publication called Arkansas Business that you know has those resources available and keeps those. So that's one resource that we use.
Okay, great. Let's go to Dana now. Dana, I think this is a great question for you from Jill Yegian. What has been the most compelling value proposition for these ERISA employers to voluntarily contribute to data? What do you tell them? What's the best thing that you can tell an employer that makes them say, oh yeah, sure, if that's the case, then I want to be in?
So in our state and probably many others, cost is, you know, the number one thing that they're interested in, right? But we're, I guess, maybe a little bit of an anomaly in that we don't have a lot of super large health plans. We have many health plans, but many of them only have, say, maybe 100 to 200,000 people at most. And the same is true for our employers. So we don't have any Walmart here in Wisconsin. You know, we don't have these mega employers, but we have a lot of small and mid-sized employers. And what that means is both for, you know, the health plans as well as the employers, they don't really have enough data to do analysis very deeply, right? Anytime you try and segment out, they're getting down to only having a couple of claims for any particular one thing. So the value proposition that we talk a lot about is the ability to use the whole state's database as opposed to just your own experience in order to be able to go much more broadly and look much more deeply. And in particular, they want cost information and ultimately value, so cost and quality information. So that's, I think we've come a long way, particularly working with one of our employer coalitions and helping the employers to do that. And we actually have a big statewide project that we've done with them. So they're really on board. We just got to get their TPAs and others to actually give in and give us the data.
Okay, thank you. So let's go now to Pete. Pete, I'm gonna take this one from Jill. Does your organization prepare the business case and value proposition yourself, or do you rely on partner organizations to take the lead on that messaging and that business case?
That's a great question. It's a little of both. We believe we can articulate the value proposition, and going back to the previous question, what do you tell people? Well, it's benchmarking. It's helping them understand what those costs are and providing some context in terms of county level, state level, other ways we can slice and dice the data to help them understand the context of their numbers compared to others, and help them understand kind of, what are the drivers of that in their community. We have some sense of how to bring that value proposition and articulate it, but we've also done a lot of work with our employer coalitions and partners to help understand what's most important to the individual employers or group of employers to help fine tune that.
Okay, great. Thanks. Craig, I'm going to give you these questions from Olga. In addition to Natalie's question, how do you determine who the self-funded employer's ASO or TPA is? Because you got to get the data from somebody. And what do you think the cost might be to the employer if they want their TPA or ASO to submit their data on their behalf through a voluntary model?
Ooh, those are both good questions that are normally, I mean, the second one certainly is, going to be proprietary in nature because the TPA is going to price that differently and work that into their proposal for managing the administration of the plan. Yeah, I mean, I go back to in Arkansas, it's a small state, so you do a lot of asking around. We, like Dana in Wisconsin, have probably three very large health plans that operate in Arkansas, and so it's sometimes by a process of elimination and going to those larger ones first. And then I did want to mention something on the. I really appreciate the transparency of the process that Pete and Civic have laid out in their process for self-funded employers to go ahead and sign up and opt in. I think that's something that would benefit us here, is having something kind of canned that we're able to take to the large employers. I think one of the things that we've tried to do is follow the energy, and I think that a canned way of going about it would be a great addition to that. But certainly, we as a policy organization have a history of working and finding the policy window. So where there's energy and where there's something that's going on, like there is in Northwest Arkansas, we want to find a way to kind of work our way into that and find a benefit that can be sustained over time and engage them in that fashion as well.
All right, let's go to Dana. Yeah, and Olga says, good idea. I thought that maybe a toolkit would be helpful. So that's very good. But back to you, Dana. Access to your data and analytics. Is there a way for the public? Is there a publicly available format? Do you have to have a subscription? What are your restrictions on who can use your data in Wisconsin? I know it's going to be different for every state, so maybe just have each of you just answer this in 10 seconds.
Yes, so there's no restriction per se, as long as the use of the data is within our kind of approved uses, which is really cost evaluation, quality, safety, those types of things. We don't really allow it for marketing, for example.
Mm-hmm.
But I think from the complexity of it, it would be difficult for the public. We used to run a public website, and we provided a fair amount of information, but quite frankly, nobody used it. So we took it down. I think there is a new opportunity to provide information to the public, but I think, just based on my years of experience working with transparency in healthcare information, we need to have better delivery models than a public website to do that.
Okay, and then Pete, you want to just give us a quick intro as to how your data is available, and then Craig, the same question.
Sure. Similar to Dana, we've got outlines in terms of how the data can be used. There has to be a benefit to the state of Colorado of some sort in order for us to release the data, but the data can be released, and we have a legislative mandate to release the data to a wide variety of stakeholders that have an interest in it and also can meet that benefit to the state of Colorado. And that runs from small nonprofits, employer groups, the state itself, other governmental entities, digital health, as well as researchers. We get a lot of interest from researchers both here in Colorado and from around the country.
Okay, and Craig?
Yeah, same as Pete and Dana. It's got to be used for the kind of the benefit of the residents of the state. Our language and our limiting structure is solely for proprietary use. If they're going to use it solely for proprietary use, that's not going to pass muster with our board or the commissioner. And I just want to put a pin in the research aspect that Pete mentioned. I don't feel like probably these large employers have a significant interest in having a corporate responsibility toward providing data to do research. But if you look at that from an economic development standpoint and the funding that brings into a state, particularly like for employers who have their headquarters in your state, I think that's an undersold selling point.
Okay, we got time for one last question. This one's just real quick for Arkansas and Colorado. Are you getting allowed amounts from the voluntary submitters, and are you worried if you're not? Pete, and then Craig, and then Dana, if you want to just wrap us up on that thought as well.
We have a standard submission, what we call our data submission guide. So all the files have to be submitted the same way from our commercial payers and everybody else who's submitting the data. So that is a part of what we receive, and we can break the data down by total cost or total paid amount, what the plan paid and what the patient paid.
Okay, Craig?
Yeah, I would say the same. And then, of course, the data use agreement with that entity is going to govern how those data points get to be used.
So we also have a standard data intake layout, but allowed amounts is optional. I'm hopeful that as some of these other transparency types of requirements come along, that people will kind of ease up on that a little bit, because, well, I agree. I think it was Craig who talked about how difficult it is to use that information right now. I think it will get better over time, which is somewhat a threat to us unless we are the ones who learn how to do that and leverage that information to increase the value of our organizations on behalf of our states.
Well, thank you all, everyone. We've now got to the end of our time, and it's been a fabulous hour spending with you understanding this incredibly important and interesting topic. We thank you. Those of you who are interested in sharing this with your colleagues, we have recorded it, and it will be available on the NADO website probably within a day or two. If you have any questions about how to find that, just shoot us an email at info@nado.org. Thank you, everyone, and we'll see you again soon.